Okay. So I'm Brian Arndt. I'm a family physician who does full scope family medicine here in Madison, OB, hospital care, clinic care. I have a wife that's a physician as well. I have 3 little girls. And part of my motivation to think about this is in that vein, in that context. Like, there's a lot going on in my life, and I know there's a lot going on in other people's lives. Like, we need to be decompressed a little bit, and so I'm excited to be here to talk about that. I just wanted to introduce Michelle as well, Michelle Watkinson. She worked with us as a summer student, SSRCA work. I don't know if you're familiar with that, but it's a program that the Department of Family Medicine hosts 8 weeks, I think, for students, and paid research opportunities to work with us. And so thanks to Michelle for really great work that she contributed to this. So I don't have anything to disclose. I don't have any conflicts. Just a few things here that we'll want to make sure that we all recognize by the end of the presentation, which is how does the work that we do impact us in terms of physician burnout? How might we be able to use EHR data that's validated by direct observation as a way to describe the work that we're doing? And then how might we encourage healthcare organizations to use this type of framework for their own dialogue internally or externally? So I put this here just for one reason, and that is to say 99% of the things that we do during our day are really productive interactions, and people are very happy and satisfied. But of course, this type of experience, as a medical director at a clinic that has 30 clinicians, I get a lot of feedback about just the things that don't go so well, and that's kind of hard to take. And so then you take that and you're like, well, then other things happen in your life. My daughter had open heart surgery, and that was a scary time of my life. And then one of my twins, her twin got sick, and her other twin got sick again the next year. They're healthy, happy little girls now. But because of the circumstances of my life, we had to kind of sell our house and come up with a different house. And during that time, I was attending at St. Mary's, and we had some challenging circumstances with our residents. And then I was getting the information from the in-basket saying, gosh, you've got incomplete charts, and you've got 44 charts to review. And by the way, as the medical director, you get the provider open chart penalty report that says your charts and other people's charts are open. And this was coming at me. I'm like, oh my gosh, how much more can I take, right? And it's part of that that contributes to why we feel the way we feel as physicians. So just showing you here in the center, and I'm sorry, John, I don't know if you guys want to move there because I feel like I'm standing in front of you. I hope you can see around me, see through me. I'm transparent. But burnout among all specialties in medicine has increased, primarily over the last 5 to 6 years in particular. And this is some work by Tate Shanafelt up in Mayo that says, comparing 2011 to 2014 data, the burnout rate across the disciplines in general was 45% compared to 54% in just a short period of time. Family medicine, I called out here separately, during that same period of time was 51%, 63% 3 years later. That's a fair number of people that are burned out, quote unquote. And then from some work that John did with the Wisconsin Medical Society data that he published, 80% of Wisconsin physicians in I don't know, all physicians or which disciplines? Across the board. So in Wisconsin, why are we higher than the national average? I don't know, but that is what it is. So 80% potentially of the people that you're working with, 4 out of 5, are at risk, and these risks are substantial. And part of it is that, many people would say it's because we're bombarded and we're doing the wrong work. We're constantly doing paperwork and administrative things that really don't matter, and where's the value, etc. If I could just spend my time providing productive patient interactions, I'd be probably pretty happy, and because that's what I went to school to do and wish I would be doing and would hope to do. So we're doing the wrong work. An extension then of Tate's work was to say, well, for those people that are burned out, which are all these people, burnout is on the x-axis, satisfaction with their clerical burden is on the y-axis. A higher number on the clerical burden satisfaction would be a good thing. A lower number on the burnout scale would be a good thing. So those people that are in the bottom right are very burned out and really dissatisfied with the amount of clerical work that they do. So if you look at family medicine, again, I just am picking on us because it's my discipline, close to 65%, like we said before, 63% burned out, and about 27%, so 1 out of 4 people who work in family medicine are satisfied with the amount of clerical burden that they have, and this was a 2016 study. So I think that probably is representative of the family physicians in the room. I wonder which one of us is happy about it. I'd like to talk with you more.
I love my clinical work.
Right? So just all, right? Yeah. So just as a disclaimer, I've given Krasinski some credit on her slides. I've just grabbed a couple of her slides directly. I didn't want to change them because they were her conclusions. And so from the paper that she just published 2 months ago now, in the Annals of Internal Medicine, I think many of you probably had seen this, which says there's a nearly 2-to-1 ratio on the EHR and desk work to the direct clinical care time that physicians are spending. And then what she did was, in her study through a variety of institutions across 4 disciplines, which was orthopedic surgery, cardiology, family medicine, and internal medicine, she asked those physicians to go home at the end of the day and also keep track of, through diaries, how much time are you spending on additional work once you leave your building, quote unquote, where you're doing your care. And the average was 1 to 2 hours per night. And so we'll come back to that. And then finally, her conclusion was that, you know, those practices that do have documentation support in the form of scribes or transcription to dictation, et cetera, you obviously get increased face time with patients. And so let's just talk a little bit then about our local data. So essentially the next few slides, what I'm going to just describe to you is that our panel of patients at UW Health is increased substantially. The head count and the clinical FTE of the physicians providing care to that head count is decreased. So more patients, fewer providers. And partly what's happening is that clinic visits are increasing, as are telephone calls, medication refills, MyChart encounters. Just to show you separately here, in family medicine, just to talk about that for a second, over the 3-year period, it's not summarized on the far right, but I have the summary data now. MyChart data, our number of touches that we provide as family physicians, the number of touches that I actually touch in MyChart over the last 3 years has increased by 60%, 62%. The number of telephone calls have increased by 6%. The number of refills I don't have right here, but they've also increased by 3 to 5%. The face time with patients, the number of patients per hour, that's one of the metrics that we follow, remains 2.2 patients per hour. So if you can do the math, it says you see as many patients as you used to, but you've had a 62% increase in MyChart, a 6% increase in telephone, a 3 to 5% increase in refills. You're still one person doing what you were potentially doing before, but now with the numbers not adding up. Where is that spilling into? We then said, well, let's continue to be progressive here and provide even more opportunities for patients to connect with us. So for a copay, I believe it's $25 for 7 or 8 different conditions: UTI, red eye, back pain, sinusitis. Drawing a blank on what the other ones are offhand, but why don't we offer this too? And then we'll have the physicians provide oversight. We'll ask the advanced practice providers to actually do this through the electronic communication, but please provide oversight, Al, on those people. And you can see, since introducing that, there's been a big uptake. This is old data by a year already. It's twice that in the last year. The nurses, well, we say, why don't we redistribute? Why don't we shift some of the work from the physicians to the nursing team? In my clinic alone, we've doubled. We've actually increased over the last 3 years. We've doubled from about 130 RN visits per month to about 250 RN visits per month. We have not doubled the RN workforce. They're still managing, at my clinic, 112 anticoagulation patients and doing triage calls and doing floor work, et cetera. So as we're shifting work, we're also shifting it to other people at risk for the same circumstances of professional dissatisfaction and burnout that we're facing because of workload. It's just not sustainable, and the numbers there just keep saying that. So a couple years ago, I, along with a few other authors, did a survey of clinicians, of all the primary care clinicians at UW, so internal medicine, family medicine, and pediatrics. And we asked people to provide us some input about, what kind of workload do you actually feel? What kind of strain do you actually feel when you provide certain types of work? We asked them to think about it through the NASA TLX framework. I don't know if people are familiar with this, but just briefly, NASA TLX, it's got different categories of mental demands, physical demands, temporal or time demands, performance, how successful do you think you are at things, effort, how hard do you have to work to accomplish this, and how frustrated do you get by doing this work. These were the things that we said, considering all these certain encounter types that we do, give us some ratings on the workload associated with each of those. I asked them to think about the reference point being a established patient level 3 office visit. We used to think of that as like the bread and butter type of office visit in family medicine. The relative value unit, the work RVU for that, is 0.97. So for purposes of this, we said, let's call that the reference of 1.0. Think about all these other encounter types that you do in person, not in person, in the hospital, in the clinic, and tell us relative to that 1.0, more or less work. And in particular, I want to draw your attention to a couple things. One is that the clinicians in this are very good through their survey relative to the work RVUs that are established. So for example, a new patient age 40 to 64 in a preventive health visit, the established work RVU is 2.33. The 185 physicians that answered that question came back with, on their slider scale, they could slide this button, they came back with 2.55 relative to the 1.0. So that's a very good ability to have the physician say, I think this is the amount of work that it is, especially when you compare it to the work RVU, if you believe the work RVU scale is a good one. So with that, we said, well, let's believe what they have to say about the non-face-to-face work. How much value, how much work, how much effort, frustration, time demands, etc., do they think these non-face-to-face activities actually deserve in terms of, if we were to create an RVU for them, how much credit would we give them? So what you can see there is that between supervising a nurse visit and doing a telephone call, it's about 0.3 to 0.63 work RVUs. So anywhere from a third of an established patient office visit level 3 to 2/3 the value of an established patient level 3 office visit. So that was a paper that just said, well, can you give us some input about, does there seem to be some value with that non-face-to-face work, and if so, how much value might it be? Okay. I'm not Catholic, but my wife always tells me I'd be a good one because I have a lot of guilt, and so this probably isn't the solution, but I thought, and others thought, that maybe we could start exploring the data a little bit further to better understand, okay, now we know what clinicians think about these things, and we've heard loud and clear from them for a long time, me included, that it's just too much, but we haven't had an ability to quantify how much are they doing of what certain things are they doing that's really dragging them down. So that's what we set out to explore. But as you know, for those of you that are engaged in electronic health record sort of evaluation, even though big data is good, right, there is a tremendous amount of buried deep within the EHR, the answers, but how do you get to those buried answers is really, really difficult. So separating the wheat from the chaff, there's been papers, in the lay press, New York Post and others just talking about that, and it's really difficult to do. But we set out to try to work on that. So how much work in the EHR do we do as clinical versus how much is administrative? And when you're doing any of those types of works, when are you actually doing that work? Is it during the actual day when you're supposed to be working? And we define that as 8 to 6. That was in mutual agreement with the department chair to say, is that a reasonable expectation for us to be working between 8 and 6? And anything beyond that to be called unreasonable or after hours, before 8 a.m. or after 6 p.m. So just so you know where we're basing this from. So what we did is we looked back in retrospect over 3 years of data between July of 13 and June of 16. So we just finished this evaluation just last month. We had 142 family physicians in this group that we evaluated. The average clinical experience is 20.1 years, so it's an experienced group of clinicians. And we looked at both domains in which we live, which is in the residency clinic world and the non-residency clinic world. We looked at user access log data. So that is, when I log in, there's a record of where did I log in, what did I do when I logged in, what exactly did I do, did I go to medications, did I review those, did I look in the problem list, did I do chart review, what did I do, did I document, etc. That's all part of the user access log. We then set out and said, well, there's 1,000+ events that are recorded in the user access log. Let's try to put those into some categories that make sense to people to talk about and think about, and how can we put all 1,000 into separate categories that can be talked about in a practical way. And then not only did we look at log data, but we also had Michelle, the student, spend 50 hours observing activities that occurred during the day so that we could say, when we started to look at access data through these logs, how might we also relate through a real person what actually did occur so that we could believe the log data once we actually looked at it. I'd really like your input on this, and not right at the moment, but maybe as we near the end we can come back to this. So from those 1,000+ events that occur in the EHR, I broke these down into 15 separate categories. And I've broken those 15 categories into kind of 3 broader categories. We provide medical care, we do things within the in-basket, and then we do things that are more clerical or administrative. The 15 subcategories then within those 3 are in medical care. There's a variety of different ways in which we do chart review. These are all called out as separate items within the event logs. We can look at images and the documentation about those images. We can review labs. We can review medications. We can look at notes. We can look at, many health records have within them a launch into like evidence-based medicine resources, micromedics, up-to-date, etc. We can review or edit the problem list. I think those are medically oriented things that we do. We need to separate that from, we also kind of provide medical care through the in-basket asynchronously, but in-basket people describe as the suck of my life. It really draws me down, and all I do is spend all my time in the in-basket. So we wanted to look at that as a separate category. And within that, the in-box we just called separately in-basket, which might include letters, MyChart, communication with patients, telephone calls back and forth with patients, and then clerical things that we do. Administrative would be, I look into demographics to get a patient's phone number. I might review my schedule with somebody in a huddle. Billing and coding, when I actually apply a CPT or ICD-10 within a visit. Documentation, when we're actually typing into something and describing what it was that we saw with the person in front of us. Providing orders, CPOE, some of you have heard about, computerized physician order entry. We just called it order entry. In system security, logging in, logging out, breaking the glass. If we're going to review psychiatric records, we're already logged in securely. Why would we need to go through a whole nother separate process? So I'd be curious to hear your reflections on this afterwards. Of those PCPs that we looked at in this data, we had a variety from community and residency clinics. We had a pretty decent balance between sex. We had, like I said, a lot of experience in clinical practice. I do want to draw your attention, though, to clinical FTE. If you notice here, from a percentage, only 28% are considered to be full-time clinicians. And you might say, well, that's because you guys are a residency, right? I mean, well, it turns out that as a residency, only 44 of us were in that data, where we had 98 that were community-based or regional-based physicians who are non-core faculty resident teachers. I think that some of this that we're talking about today has something to do with the clinical FTE being across the board far less than 1.0 or 0.9, full-time, quote-unquote. Picture of Wengen here. We sometimes refer to him as the Wizard of Oz or the man behind the curtain. I had everything to do with it. Sorry to put you in that position, but I think the reason this is here is it's really important to say that the kind of output that we get from this type of evaluation can't be done without a great partnership between, clinicians that want to ask questions, department chairs that want to get answers, and the people that actually can find them. And people that can find them in a way that understands context and kind of knows what you're going after. Because you talk about wheat from the chaff, I mean, it's far worse in the weeds that they go, and they need to bring back to us something that makes sense. So here's just an example of the user access log data. So it would show just many million lines, 118 million lines of output we had. And it would show the date, the time, what actually occurred in this metric name, whatever category this was. And then those 1,000 plus that I talked about are in that metric name column that we had I guess rounded up into those 15 categories, a little bit of a description that was next to it, and then the patient that it belonged to. So I don't really have any more answers to describe what it was other than we looked at a lot of data, we put it into these categories, and then started to study each of those categories separately. I'm going to just pass the baton here to Michelle here for a few minutes.
Okay, so as Brian mentioned, I was doing direct observation to try to correlate with the massive data logs that OneGen was looking at. And I was observing both the direct patient care and the non-face-to-face patient care. So I followed 14 non-resident family physicians throughout their entire clinic sessions over a 6-week period this summer, which was a subset of the time that OneGen looked at the data. We did targeted sampling. It was only 14, but we wanted it to be somewhat representative of the population of physicians, and we had a pretty even gender split. Years of experience was really variable. Clinical FTE, again, varied from 3 to 9. Clinical setting varied, and self-reported experience with EHR, because the idea was maybe people that have less experience would be less efficient. So we wanted to get the spectrum of that as well. So my goal was to be a fly on the wall and observe a physician through their entire work session. A work session was one patient care session, so a morning or an afternoon. So I would contact the physician, go in first thing, and whenever they said they were going to arrive at the clinic, I would try to be there at the same time and follow them from that moment until that morning session was finished and until their next session began, because lunch breaks weren't really a thing. They were finishing work from the morning, so I wanted to account for that too until they really made the switch into the next session. And I recorded both EHR work task categories and additional non-EHR categories, because that's the advantage of being a person rather than a data log. I used an app on the iPad that was called Work Study Plus, and it allowed me, this is what my screen looked like, and it had all of these different categories that as soon as I pressed the button, it would start recording the time, which you can see on the right. There's also a lot of subcategories in these. Once you click, it gives you more options. So that was the tool that I used to try my best to record every click that happened throughout the day. So here is what we found, is that 40% of these family physicians' time was spent on the EMR, and 60% was non-EMR. So honestly, my first impression with this data was actually that it wasn't as bad as a lot of people thought. The impression I got from speaking with a lot of these physicians was that 100% of their day was glued to the computer, and that was not the case. But I think the data that Brian brings up about the clerical work burden being too high and the burnout rate being too high means that 40% is potentially still too high. Additionally, I'll show you, but some of the non-EMR stuff isn't just direct clinical care. So here's that pie chart broken down a little further. The biggest chunk, which is reassuring, is that 37% is direct clinical care. And I classified that as non-EMR clinical care, so I tried my best to distinguish from when physicians were multitasking and documenting about their patients and actually doing a physical exam or focusing on the patient as part of the history. And so the break was really, if hands were on the keyboard, counts as multitasking. If hands are not on the keyboard, it was direct clinical care. So this data is in line with Krasinski's work that about a third of the time is direct patient care. The next big chunks, 15% is documentation. 15% is non-EMR other, so that included a lot of like transit time, honestly, was a pretty big category. Personal conversations, which isn't necessarily to say not work related. There's a big value in building rapport within the office, and personal tasks as well. And then 6% is non-EMR administrative, so signing paperwork, things like that, and email also in that. So this is the non-EHR time, the 60% broken down into its own pie chart. So again, about 2/3 of that was clinical care. That other is the same category I just talked about. The administrative, 10% of that time is email, signing paperwork again. And documentation, non-EHR documentation was people doing dictation, or a few physicians were taking paper notes while in the patient room. So it's a minority, but that is the case. So here's how that EHR time broke down. 37%, it really is a different pie chart. It looks very similar, but 37% of that is documentation, followed by reviewing notes, order entry, and in basket, everyone's favorite, is 8% of that time.
So essentially what we did then is to say, okay, now we know in real people speak, through direct observation, what actually happened. Then we went and explored what did the access logs show us in correlation. Again, this I'd like some feedback on when we're done, but essentially by those 3 broad categories, in the subcategories within each of those broad categories, this all represents 100% of the EHR time that we spend, but it's broken down. And so let's just look at it a little bit separately. If you noticed in Michelle's EHR time slide, she showed 37% of her time that she observed with EHR-related activities was documentation. Our log data would show 23.7%. Remember, we are looking back 3 years over 142 clinicians. She was looking back 8 weeks over 14 physicians, many of whom had less experience than the average of the 142, which is 20 years. She saw 1 to 15 years. Some people inexperienced on the EHR, some people experienced. So just wanted to clarify the difference between what she saw and what we saw. But essentially what I want you to look at is that of the 100% EHR time that we do, there's certain things that stick out. I do think that a quarter of our time being documentation time is quite a lot. I do think that 12% of our time providing orders is quite a lot. Not only do you pay attention to the far right column, but I want you to pay attention to the actual number of minutes that are spent. And when are those minutes spent? Let's just pick on order entry for a second. So 43 minutes in total would be spent per day on average by these physicians, 142 physicians over that last 3-year period. 35 minutes of that order-related work in the EHR occurred during work hours. 8 minutes occurred outside of work hours. And then you can see what's the ratio. There's 4.4 times as much order entry time spent during the day compared to order entry time spent outside of the workday, outside of 8 to 6. For me, for example, as I look at that displayed in this way, I would say, organization X, the challenge to you would be to, while the physicians are working during the day, to eliminate not 43, but initially to try to work to eliminate the 35. Because when I don't have the team of people surrounding me before work hours and after work hours, like before 8 a.m. and after 6 p.m., that's my work time, and somehow there's still some things that spill over. A good example would be, I did an evaluation today on a guy who I'm concerned has osteomyelitis. I saw a big ulcer on his toe. During clinic today, I ordered some lab work, ESR, CRP, blood counts. I get the results later in the day. I see, wow, my suspicion is maybe true. There's evidence of abnormal labs, and now I think, okay, I should pull the trigger for the MRI. So I might have ordered that MRI at 6:30 at night because of the data that became available as the day progressed. I'm not certain that that's something that should be taken away, quote unquote, by the team that can support me in doing orders. Maybe, maybe not, but I just want you to look at it in this way. The other thing I guess that's important to look at as it's laid out this way is that the relative ranking in certain categories. So some things that we pick on are, in general, 44% of our job is clerical in the EHR, administrative, whether or not these are the right categories and the right compartments. Let's see. So we can look at the broad categories, 44%, 31%, 24%. There seems to be an abnormal distribution of where we're placing our effort. Why should we be having more effort in clerical work than we have in actual interpretation and medical care within the EHR? We've looked at this in other ways, and to say, wow, we spend 14 minutes in billing and coding. What might happen if that 14 minutes were replaced by professional billers and coders? Well, what would happen is that John would have another 15 minutes with another patient, so access improves. By John seeing that patient, he's developing revenue so that he can pay that person to do the professional. You get the gist of how I think we can start making some broader recommendations based on the data in this way. This is one thing that I think John was alluding to in one of the slides that maybe Chris didn't show the other day that people asked about, and this has been the thing that's been commonly referred to as pajama time. And it came from our work, and this is why. So essentially what this shows across the x-axis is the hours of a day. Of course, there's only 24 hours in any given day. And then on the y-axis is of the login times that we had, what percent was spent at each hour of the day. And so this is cumulatively across left to right, needing to equate, during weekdays and weekends, each to 100%. And I think what's striking to me is that obviously during the weekday, you see a big percentage pretty evenly across the board between routine work hours of about 8 and 6, right? 8 a.m. and 6 p.m. But what's not so great is on weekends, you have a cup of coffee and read the paper, and then at 10 a.m. the first thing you do is you hit the EHR. And you kind of do that throughout the day, but it tails off. Maybe you went to your child's soccer game, but then boom, you hit it again at 10 o'clock at night. There's this bimodal distribution of when you're doing your work. That's supposed to be like date time and like romance time and like child, movie time and whatever, not EHR time. So that's I think Chris coined the term pajama time. So what you can't see in this is at what point am I face-to-face with somebody or not face-to-face with somebody. It's just saying, on average, on any given day, the things that you do, this is what you do by category, and this is when you do it. You might have a patient in front of you, you might not. So that we can't tell. We have talked about, well, sure, we can equate our master templates, our schedules, of I'm scheduled to see patients 8:30 to 12. How much do I do that might be between 8:30 and 12 that we might attribute to an individual patient care session versus outside of that? There's so many ways to parse this data. I think first thing that we're trying to do is to say, are these categories that we can have conversations about? Are these meaningful output products that we can have meaningful conversation about? And then what might be, for example, the patient characteristics behind why somebody might spend more time documenting or placing orders or whatever. So we can spin it a lot of different ways down the road. This is a slide that John asked Wenjen to look at is, for example, back to the weekdays, weeknights thing, is that, what percentage of the charts are getting closed on the day that the chart is opened with the patient? Turns out that percent closed, let's see, what is that, 70, 60, 71% are closed on the same day. All others are closed on subsequent days. And you can see as 0 to 14 days go on, 2 weeks later, when you're going to close a chart 2 weeks out, you're most likely to work on that after hours, is essentially what this shows. John, that's your slide. Do you want to mention anything more about it? Okay. So documentation. I have used Dragon, and I don't use it much anymore because this kind of thing happens a lot. Eye and thigh, hips and lips, and it's, even though you can train it and you're supposed to be able to get it to recognize and be good at what it's supposed to do, it's really challenging actually to spend the time training a documentation support tool when you're in the tyranny of the urgent trying to do everything else. So therefore, my uptake of Dragon has not continued like I expected it might. And I know Chris would say it's been a major drain on their practice for those folks that have used it. Some people use it and use it efficiently, others not as much. this is a slide that's given credit to her also from her study, again, from those 4 disciplines of cardiology, orthopedic surgery, family medicine, and internal medicine. Some people had no documentation support, some people had dictation support, and some people had scribes or team documentation support. And really all this is showing is that, and it makes sense, if you have documentation support in the form of a scribe sitting behind you, you're 43.9% of the time spending it with patients in direct FaceTime, whereas if you don't have documentation support in any way, shape, or form, and you're doing EMR typing and templates, within the EMR, you have 23% of your time spent with patients. This is kind of meaningful. Is this a metric that we care about or don't we? Do our patients care about it or don't they? I think this influences how I might convince Val to support scribes or not, for example. And her summary of the benefits of providing this support: it saves time, it boosts productivity, it increases capacity and access, improves quality, improves patient and provider satisfaction. That's what we're talking about. And then, back to orders, I don't know, Al, if you've gotten a way to do this, but since ICD-10, in this new calculator that we have to apply a diagnosis,
It's a pain point.
it's a pain point. There are 29 different things for me to select to choose gout as a diagnosis. 1, 2, 3, 4, 5, 6 different subcategories, all of which have to be addressed for me to be able to apply gout with the patient in front of me today to their diagnosis codes. 29 options just for gout. Then I was like, oh, I'm gonna beat this. I'm gonna do well. Not just anemia. I'm gonna call it iron deficiency anemia. I'm gonna order these things, and I'm gonna make sure I've got a specific enough diagnosis. It says the following are not specific enough for billing. Iron deficiency anemia is not good enough. So then I was like, well, what am I supposed to choose? In order for it to acknowledge and accept it, it's iron deficiency anemia, comma, unspecified iron deficiency anemia type. I don't even know what it means. I mean, Al's done medicine a lot longer than I have, but I'm not sure what more did it want.
Iron deficiency anemia times 2.
Oh, there you go, right? And that's essentially how I read that. It's just adding this level of bureaucracy and redundancy that's only frustrating me. I mean, I'm more gray and more bald in the last ICD 9 to 10 conversion than I was before. And this is partly why we're saying, hey, let's look at billing and coding as a separate category, because suddenly I might have a way to influence the government or whoever that, gee, this ICD-9 and ICD-10 thing, I get why it's important and why you think it matters, and you want to classify gunshot wounds of the lower abdomen, and you want to look at all the people that have that and how well they're doing. But this is an unintended consequence. When we look at pre-ICD-10 and post-ICD-10, how much time we're spending in billing and coding, if it turns out we're spending 50% more time, maybe that has some policy implications. Go ahead, John.
Although it wouldn't be just the billing and coding, it's exactly what you have up there. You want to order a hemoglobin, and that would then be recorded time and order entry, I suspect, wouldn't you? Not time as billing and coding, because the actual activity is order entry.
It first would have gathered this in order entry. It would have captured that. And then as I struggled down here, it would have captured this. And then as I went and clicked combinations and associations, it would have gathered that as order entry time. So we have separated those two as two distinctive situations. Then, logging in and logging out in system security. So, I have to go through Citrix. This is the number of screens that it goes through when I'm remotely logging in to just access it. Then I have to put in my username, and then I, of course, type it wrongly, right, many times. And then the first thing that I do when I get in, I want to make my green dots black. Black means patient chart note complete. These are not complete. The very first thing it does is it says, you've got a whole bunch of stuff in your in basket waiting for you to do. Don't mess with this. Go here. I'm like, no kidding, right? And it's like, that's really hard on your psyche to see this. I like EHR alerts when they work well, but that's just kicking you while you're down, Then back to the categorization. I didn't call it out because I thought I'd call it out here. We spend just about as much time from that one table showing the amount of time that we spend on logging in and logging out, system security. We spend just about as much time on problem list management. We spend 11 minutes per day, I think, on logging in, logging out, or maybe problem list and 10 minutes logging in, logging out. It's 10 or 11 minutes, but they're both about the same. To me, that's pretty wrong. I mean, I feel like we should be spending a lot of time making sure problem lists are up to date, we review them, we edit them, but the system security is a big suck on us. I'll just take this to a different level then and talk just a few more minutes about a few things. So we've been thinking about this, talking about this, working on this for a couple years. We've now become, I guess, official partners, if you will, with Epic, the developer Epic, not just like the people at UW Health who make Epic look like it's supposed to function within our organization. We're working with them on this thing called the Provider Efficiency Profile. I think it's the wrong name, it's their name. But essentially what it is it's looking at all these tasks that we're doing and how are we doing on those tasks that we do and how might we suggest, based on the output that it shows, optimization, or you might need additional support, or this data tells us that you might be struggling in this arena, how might we help you? This was my data from a 3-week period. This is only available over 3 weeks because it takes so much suck on the system to analyze every tick and tally that occurs in the EHR. They can only look 3 weeks at a time. So that's one benefit with our 3-year look back, through our data. It's slightly different than this, but essentially what they're going to do is take 3 weeks, 3 weeks, 3 weeks, 3 weeks, collate those into a longitudinal look. But this again was 3 weeks looking at me, 2 of which I happened to be inpatient attending. This was the first time I had seen my data. They didn't know what I was doing when I was doing it, but they wanted to talk to me and they had a few questions for me. So one question they had for me, they're like, I see, Brian here in the blue, and the Department of Family Medicine average as being pretty different. How come you turn around prescriptions 4 times faster than other people? How come you turn around patient calls 10 times faster than your partners? How come you do that? And I was like, well, during the day I'm in my in-basket all the time because I need my team to help me. If I have a concern or I need some more information, please call the patient back to get at this. I don't have it on this slide, but another one of their little graphs would say, I'm slightly delayed in closing my charts within the appropriate time. But they're like, so do you sacrifice like documenting and closing patient charts at a cost of? I said, well, it's not a cost, but do you sacrifice so that you can, it's a benefit, right? I said, I think as a patient, I want my questions answered. My patient satisfaction survey results are like 98 or 100% on I get my questions answered in a timely fashion. Whether that's in a metric that I care about or we should care about, this allows us to get at things at sort of an administrative level. As a resident supervisor, I might look at some of this and say, well, gosh, you're on the opposite end. We need to work on that together. So Michelle has said, isn't this stuff kind of punitive? When you show this to people, don't people get a little bit defensive? And absolutely. So I think we're working with them simultaneously to say there are certain outputs here that are helpful, but I think could be more helpful put in context or adjacent to these other things that say, well, we see you do this, but gosh, you're so great at this. I can see why you do so much of this. But I wonder if you could talk to your medical director about his perspective as to should that be the right, place of emphasis. If you want to make things different, you have to do something about it. And so, many of you have seen, I keep bringing up Chris's name here, but, Chris published back in 2013, The Joy in Practice, and really it was just 5 tenets that kind of made a difference on some of these things in the EHR time spent. If you reach out to people in advance and do pre-appointment planning, and if you work with teams and they have protocols in the room that they can fill medications in advance and have standing orders to do things and have panel management activities, et cetera, can you shift some of the clerical administrative to partners? Can you actually co-locate and verbally communicate rather than ping back and forth in the chart about, can you do this for me in the in-basket when you could just have a conversation to eliminate 5 bounces back and forth? I think people are familiar with that. But this is becoming just a constant conversation about the influence that these tasks are having on us. This was just in Medscape, for example, last week. And how do you overcome it? And delegation and sign off on some of this, or spin off some of this EHR burden to other people. There's Mark Linzer and others who are saying there's 10 steps that you can take. One is decreasing stress from the electronic health records, promote physician control. I mean, the point is there's some people that are much smarter than me that have figured out ways how to mitigate some of this. Phil Bain from Dean, who I'm sorry wasn't here this morning, I thought he could maybe comment on this, but they said, well, if we could just eliminate some of that system security time, how much time would we eliminate, et cetera, would be determined by however he got at this. We spent 10 or 11 minutes per day from what our data shows. He just says, well, gosh, you log in X amount of times per day and you misfire a quarter of that time, and if it takes X amount of time per login. He used the same conceptual framework that we're talking about today to say, system, we need to have single sign-on, because when we do that, we're going to decrease, effort of logging in by 17 minutes. It's the same kind of framework. Our organization saw that and said, we too should do that. Let's do a pre-post look and see what were the savings that we were able to capture from that. So in conclusion from this data, that we looked at through these log data, we spend about 6 hours every day in the EHR. 4.5 during work hours, 1.4 after work hours. This doesn't include the time that I'm at St. Mary's on the EHR when I'm attending, or when I'm on call at St. Mary's, or I'm doing deliveries at St. Mary's. It doesn't include the paperwork, the email, etc. So this is just a portion of a description of the time that we spend, so it can't be all-encompassing. They only spend 5.9 hours per day working, right, Val? I mean, that's a great point. We need to figure out how to have that conversation. We do a lot after hours, and I think the way of breaking this down can have influence on how do we reduce workload, how can we improve satisfaction, how can we reduce burnout. I think as it relates to the group here in the next 10 minutes, I think these are the type of things that can be called out by this data. When you want to go to an administrator and say, well, we need this and this is why we need it, this is how much time we're spending, gosh, if we could offload or shift or redistribute, these are some things that we could talk about more coherently by having the data sort of captured and allocated and classified in the way that we have it. So with that being said, I guess that's the end of the presentation. I'm curious, in the next 7 to 8 minutes, what reflections you have, questions you have, suggestions you have, because like I said, this is probably next week going to be submitted to the Annals of Family Medicine, and would love to hear anything that's confusing or misleading or whatever.